Air in all the wrong places. A case of Hamman syndrome in a COVID-19 patient. Spontaneous pneumomediastinum is a rare condition characterized by free air or gas within the mediastinum. Although SPM usually resolves spontaneously, it can lead to subcutaneous emphysema, classically called Hamman syndrome. The pathophysiology is believed to be due to barotrauma on the alveolar level. However, in COVID-19 patients, the mechanism is not quite understood, and patients are presenting even without some of these risk factors. The importance of identifying this condition is it can lead to severe respiratory and cardiac compromise. In this poster presentation, we will discuss a case of Hamman syndrome and the important clinical significance. A 79-year-old male with past medical history of intellectual disability and chronic kidney disease presented to the emergency department with shortness of breath. He was found to be COVID-19 positive, and initially he was managed on high-flow nasal cannula with dexamethasone 6 mg, switched later on to Solumedrol and remdesivir. On day 4, he was de-escalated to 8 liters nasal cannula. On day 7, the patient desaturated into the 80s and became tachypnic, tachycardic, and febrile. On physical exam, there was diffuse crepitus felt above the clavicles bilaterally, with expansion of the neck. You can see this image in the upper right-hand corner. The patient was intubated for impending respiratory failure. Radiographic imaging is provided in the middle panel. Notice the red arrows are pointing to subcutaneous emphysema and that it is diffuse. The yellow arrows represent the air within the mediastinum and the thoracic cavity. Notice how the air is compressing the lung parenchyma, causing the patient's symptoms. Within 8 hours of onset, the diffuse subcutaneous emphysema could be palpated in all extremities, including caudally to the patella. Despite remaining on volume-controlled ventilation for fear that positive pressure would worsen his condition, the patient also underwent bilateral anterior chest wall needle decompressions with angiocatheters and chest physiotherapy. You can see the before and after photos in the middle column as well as the upper right-hand column. The patient, however, remained hypoxemic, and eventually the decision was made to compassionately wean. Discussion. From this case, we can gather that the classic risk factors do not have to be present for somebody to develop the spontaneous pneumomediastinum and further lead to Hamman syndrome if a patient has COVID-19 infection. Because Hamman syndrome is so rare, however, increasingly seen in COVID-19 patients, especially severely ill patients, mainly the data is from case reports, and the prevalence and predominance of disease is not well known. However, from the case reports, we can gather that about 60% are male. The current theory of how COVID-19 patients develop this air leak, leading to further complications like Hamman syndrome, is not necessarily due to barotrauma, which is the classic theory, but actually the infection itself causes direct damage to the pneumocytes, type 1 and type 2, leading to alveolar membrane rupture, which goes back to why these patients might not have the common risk factors like increased intrathoracic pressure secondary to blunt trauma or bearing down or coughing, asthma, those types of risk factors. The symptoms are very nonspecific. In the literature, it shows that fever is actually the most frequent. Once on the ventilator, we decided to go against the ARDS-NET recommendation of high PEEP FiO2 ratio to a 0 PEEP high FiO2 ratio. However, that did not help his situation. He still remained hypoxemic. So the decision was made to try 14 gauge angiocatheter needle decompressions of the anterior chest wall. He did have some symptomatic relief, but he remained hypoxemic. The vitals didn't really change much with his saturations. So after multiple attempts, we went ahead and aborted. Now, we did do chest physiotherapy, which seemed to have some benefit to recruitment, it seemed like, and brought up his saturation levels, but it did not benefit outcome. Treatment for this has ranged very broadly with case reports. There's some that said that they just use high-flow nasal cannula, some methylprednisolone 20 milligrams for 3 days, and then followed by prednisone 10 milligrams for another 4. And then there's other case reports that used a chest tube, hydroxychloroquine, oseltamivir, and ceftriaxone, and there was good outcomes. Several of these case reports suggest that the onset of air leaks could happen around day 12 to day 20, and if they are to resolve, it is a long hospital course up to 40 or day 50. The reason why this is so important to identify is because there is varying outcomes. There has been some cases that have said that there was about 60% mortality with development of SPM and pneumothoraces, and others have even showed that there's upwards of 100% mortality if they developed an air leak after intubation.